So let's also talk about anesthetic adjuncts. So these are drugs that are given alongside general anesthetics to augment specific components of anesthesia. So this is done so that the general anesthesia dose is lower. So thus there are fewer side effects. So the first group of adjuncts are the benzodiazepines. So you have midazolam, lorazepam, and diazepam. So these drugs can produce anesthesia similar to that of barbiturates, but they are more commonly used for sedation rather than general anesthesia because the anesthetizing doses may cause prolonged amnesia and sedation. The most desired effects of benzodiazepines are relief for anxiety and anterograde amnesia. So these are useful for pre-medication in patients who are anxious for their upcoming surgery. So this can be given to patients before surgery. So benzodiazepines are highly lipid soluble. So they rapidly enter the CNS and they have rapid onset of action. They also have minimal depression of ventilation. However, transient apnea can follow after rapid IV. Benzodiazepines are commonly used for perioperative medication, IV sedation, and suppression of seizures also. Benzodiazepines are unique among the group of IV anesthetics in that their action can readily be terminated by administration of flumazenil, which is their selective antagonist. So, for example, the anesthesiologist gave midazolam, and then when the surgery is done, so say the patient can now be brought or transferred to the recovery room, the anesthesiologist can give a dose of flumazenil to reverse the effects of midazolam. The most commonly used is midazolam, which is used for pre-medication and for sedation during regional anesthesia and for short or brief therapeutic procedures. It actually can be used for general anesthesia also, but the disadvantage is the patient will have delayed awakening and also prolonged amnesia and sedation. So another type of drugs used as adjuncts are alpha-adrenergic agonists. So we only have one example, dexmedetomidine. So this is used for short-term sedation of critically ill adults and for sedation prior to and during surgical or other medical procedures in patients who are not intubated. So they act by activation of the alpha-2 adrenergic receptor, and it produces both sedation and analgesia. Common side effects include hypotension and bradycardia, which are attributed to the decreased catecholamine release by activation peripherally and in the CNS of the alpha-2A receptor. And we also have neuromuscular blocking agents. So we have the depolarizing, for example, the succinylcholine, and non-depolarizing muscle relaxants. We have the atracurium and vecuronium. So these muscle relaxants are often administered during the induction of anesthesia to relax the muscles of the jaw, the neck, and the airway. So this helps the anesthesiologist do laryngoscopy or endotracheal intubation much easier because the muscles of the jaw, the neck, and the airway are relaxed. So it is much easier to insert the tube. The action of non-depolarizing muscle relaxants usually is antagonized once muscle paralysis is no longer desired. The anesthesiologist usually gives an acetylcholinesterase inhibitor, for example, neostigmine or edrophonium. Also in combination with a muscarinic receptor antagonist such as atropine to offset the muscarinic activation resulting from esterase inhibition. In other words, if you want to reverse the effects of the neuromuscular blocking agents because maybe the surgery is done or you already extubated the patient, you can give neostigmine and atropine.